talk, what I'm saying is they provide blood flow to the language centers. Now, they also supply blood flow to the primary motor cortex and the primary sensory cortex. What about the posterior aspect of the brain? That's provided by the posterior cerebral artery. Okay? And the posterior cerebral artery comes from the two vertebrals. Vertebrals come up like this and join. So let's say this is the right vertebral. This is the left vertebral. These two come through the foramen magnum and they join together to form this structure here, which is the basilar artery. And then as the basilar artery terminates, it forms the right and left posterior cerebral artery. So the posterior cerebral is actually a branch of the vertebral in a sense. Now, the reason that the posterior cerebral artery, or the vertebral artery, helps you to walk is because the posterior cerebral artery supplies the occipital lobe, but also right beneath it the cerebellum. And the cerebellum is necessary for coordination. Okay? If you lose cerebellar function, then you have gait ataxia. You can't walk straight. Okay. So at the level of the brain, you have an anterior cerebral artery, a middle cerebral artery, and a posterior cerebral artery. Well, the anterior and middle are simply branches of the internal carotid artery, whereas the posterior cerebral artery on either side is derived from the vertebral. Now, the subclavian artery on either side is going to pass deep to the clavicle. So let's draw the clavicles in like this. Okay. Once that subclavian, and the name subclavian says that it passes deep to the clavicle, sub, underneath, clavicle. Once it passes deep to the clavicle, then the vessel is in the axilla. Okay. So here, as it travels through the axilla, we're going to call it, we can't call it subclavian anymore, we're going to call it the axillary artery. This would be the right axillary. This would be the left axillary. Yeah, that's the way it works. I told you that the vertebral artery on either side was a branch of the subclavian. Comes off the subclavian and passes through those transverse foramina en route to the brain. It turns out the subclavian artery has lots of branches. Okay. If you go to PA school, you have to learn lots of them. But then every vessel in the body has lots of branches. They said by the time you finish your first year of PA school or medical school, chances are you've memorized about 1 million terms. Okay? The brain has a tremendous capacity. Now, the other branch I want you guys to know about is what's called the internal mammary artery. It comes down like this. It comes down right behind the anterior chest wall. Okay. So this would be the right internal mammary artery, what we call in the biz the rema, and this would be the left internal mammary artery, what's called in the biz a lema. So the two branches off the subclavian you have to commit to memory are the vertebrals and the internal mammary artery. Now, in your book, they call them the internal thoracic arteries, but nobody says that in real life. They call them the internal mammary arteries. So that's the terminology we're going to use. If you look at Red Fred's chest here, okay, these internal mammary artery and vein here, coming down on one side, they're coming down on the other side. Okay. They feed breast tissue, they feed part of the chest wall, but they're not the only vessels that provide blood flow to those regions. Okay. The reason that we have you know the internal mammary artery on both sides is a simple reason. The internal mammary arteries are oftentimes used for coronary bypasses. What are you talking about? Okay, I'll tell you. Let's suppose somebody has a high-grade plaque here in the LAD. In fact, they may have three-vessel disease. They may have a plaque here in a certain place. And they may have disease here in the right coronary artery. Okay. But of those three vessels, probably the most crucial one in terms of survival life is the LAD. Okay. So when they do a bypass procedure, traditionally what they've done is they've taken superficial veins from the leg, like the small saphenous or a part of the great saphenous. Okay. They've stripped the valves out, and they use it as a conduit, for instance, so that they can connect one end of the saphenous vein graft to the aorta, the other end to the vessel beyond the area of blockage, like this. Okay? So that now blood's going to come up like this, come down, and bypass the blockage. We would call that a saphenous vein graft, or SVG. Okay? The problem with saphenous vein grafts is that they're not used to the pressure that exists within the arterial system. And so, at least a third of them will go ahead and thrombose about 10 years out. On the other hand, what we can also do is detach the internal mammary artery from the chest wall. We can dissect it free and take the distal end and use it as a bypass vessel. So we can connect the distal end to the LAD, for instance, connecting it beyond the area of the stenosis. So that now blood flow is going to come down like this and bypass the stenosis. Okay? That type of graft is called a Lima graft. So if somebody has a three-vessel bypass, they may use two saphenous vein grafts, but they'll reserve the Lima for the LAD. Or, this takes more time, they can use the right internal mammary artery graft to one of the other vessels. But the Lima always goes to LAD. And the value of using a Lima as a bypass graft is that at 10 years, survival is about 95%. So these grafts don't close. Back in the day, before we started using the Lima, when we used predominantly saphenous vein grafts, many patients over time required redos. And when you do a redo, it's a lot harder than the first go-round because you have to work through a lot of scar tissue. The surgery itself takes longer, and it's brought with more complications. So we try to avoid redos if possible. All right, I'll tell you something funny though. We'd have because when I did training, I trained with John Ochsner at Ochsner, and John Ochsner was outside the hospital. He was a friendly guy. He would drink a lot. He could be a lot of fun. But he was a great surgeon. But inside the OR, if you didn't do something right, he would tear you a new one. And his language was very salty. Like, he made grown men cry. Okay? But he was very confident. He was like the prototypical surgeon, extremely confident. So they would send cases from all over the United States to Ochsner because they had the best cardiovascular surgeons in the region. So the two that were at Ochsner at the time I trained was a guy named John Ochsner and Noel Mills. And these guys were pretty famous. But there was a totally different, they both had totally different approaches. Like Noel Mills would go up to a patient on a preoperative visit and would talk about, he's kind of drawing a picture of the type of surgery that's going to be done. And he'd say that this is a very difficult surgery, that the mortality rate is like 5 to 10%. He would expect that there could be complications. But with his skill and the grace of God, we hope to get you through it. Okay, we go through a long spiel like that. Okay. John, he was like a good old boy. He'd come in there and say, "Hey, how you doing? Surgery's tomorrow. Piece of cake. See you then." That would be the whole thing, and then leave the resident behind to sign the forms. Totally different approach. But all Ochsner, they call him J.O. John. All super confident. Super confident. Just don't ever step on his foot. Okay. I remember that sometimes in retracting, it'd be holding on to a little suture. Okay. And he said, "Okay, I want you to apply 30 grams of pressure. Not 1 gram more, not 1 gram less." All right, so when he's doing the surgery, you have to put just enough tension, okay, on the vessel to make him happy, okay? I'll never forget, we were doing a pacemaker, and there's this little girl, she's an x-ray tech, and she's got the fluoroscopy machine in there, okay? And you have to hold the fluoroscopy machine so you can see the wire as you're advancing it into the heart. And the fluoroscopy machine was on the blink. Okay, at first it was working and then shut off completely. And so you could tell that J.O. was getting a little bit irritated. So he said, "Fix the machine." And she said, "Well, I'm trying to." Well, the truth is, she's not some type of technician. She doesn't know. She's kind of trying to leave, call her supervisor, somebody, come back in. They said, "What's wrong with the machine?" And then, "What the F is wrong with the machine? What's wrong with you?" I mean, the little girl was crying. Okay? And I was thinking to myself, please stop. I was about to cry. Please don't go on anymore. But he just kept going and going and going. And finally her supervisor came, and but man, she was just a wreck when she left. And that was just kind of he used to, back in the day, and surgeons a lot like this, he would pinch the nurses. Okay? Nowadays, that's like off limits. You don't do that. You can't do that. And if they would complain to him, he would say, "Whose name is on the hospital?"
Oh my God.
Yeah. Like, you can't do that kind of stuff anymore. But back in the day, he got away with it. And by the way, he's locally, he's well renowned. I mean, he was king of Rex one year. But at great, if you ever had if you ever needed surgery, he was the guy to go to. But outside of the OR, it's just interesting character. He was a very, very interesting character. Okay, I don't know why I got off on that. I guess because we're talking about bypass surgery.
You probably never forget that.
I'll remember him well. Because during your training you get yelled at a lot. That's part of the deal. And I remember not being used to it, because I'd done an internal medicine residency at Charity where you kind of on your own. And to go from there to a private hospital for my cardiology fellowship was like a different experience. Because now somebody's looking over your shoulder each thing you do, because these are private patients. And so I wasn't used to getting yelled at like that. But you get used to it. All right. So, let's go over this. We talked about the ascending aorta, 2 branches. Left coronary and left main. Then we said the next component of the aorta is the aortic arch. And it's got 3 branches. Brachiocephalic, left common carotid, left subclavian. Okay. Now, the brachiocephalic trunk gives rise to the right subclavian, right common carotid. We said they're called common carotids because they bifurcate. Internal, external. The internal is the one that passes through the carotid canal and provides blood flow to the brain. Okay? That's when we went over here. And we said when it comes up, bifurcates, anterior middle cerebral artery. Okay? Now, we said there are two branches to the subclavians that you need to know. The vertebral on either side and the internal mammary artery. The vertebrals are the other two arteries that provide blood flow to the brain. We said they pass through the transverse foramina, and then they pass through the foramen magnum before they join together. So they form the basilar artery after the anastomose. The basilar artery passes along the base of the brain, hence the term basilar artery, and then it terminates by bifurcating into a right and left posterior cerebral artery, which feeds the back of the brain. Not only the occipital lobe, but the cerebellum. Okay? Now, we said that the subclavian artery on either side passes deep to the clavicle, and when it does so, it becomes the axillary artery. Okay. So we said a lot of stuff. Is it starting to sink in a little bit? Okay, I want everybody to stand up now. Everybody come out here to the hallway.